Well, good evening, everyone, and welcome. My name is Eric Glazer, and you have joined us for our latest installment of Case Studies in Diagnostic Errors. Today's session will be discussing chest pain and will be moderated by Dr. Martin Samuels, Chairman of the Department of Neurology at the Brigham and Women's Hospital. He's also a professor at Harvard Medical School. Lucky to be joined also by an esteemed panel of experts who Dr. Samuels will introduce in a moment. What's really interesting for me as a non-clinician is when we're able to get together some of the best physicians around this country to discuss complex cases and the challenges in making the right diagnosis. It's even more interesting when we get doctors together to discuss some of the errors they've made potentially around tough cases and show us examples. I think there's a lot of really good learning that comes with that, and that's hopefully what's going to result from today's panel discussion, where we'll be discussing pitfalls around diagnosing chest pain. Specifically, the panel will discuss errors in distinguishing GA causes of chest pain versus cardiac causes. We'll also be discussing the misinterpretation and underestimating of chest pain, and then the overestimating of chest pain and the rational use of the emergency department. So before I hand it off to Marty, I want to discuss three important things that you should know about Best Doctors as a takeaway from this session. First of all, if you are not familiar with Best Doctors, we provide comprehensive second opinions to patients and their treating physicians. And we do this by bringing together some of the best physicians in the country to collaborate on complex cases. And either the treating physician or the patient can initiate cases with us. And what's really neat is that neither of them have to pay for this service. We are funded by the patient's employer or their health plan. Secondly, I want you to know that we're running a pilot in conjunction with the Medical Group Management Association that would enable physicians to participate with Best Doctors as a treating physician and use our service for no cost. So if you're interested in participating in that pilot, or at least learning more about it, you could actually express your interest through a survey that we're going to put up in front of you 5 minutes before the end of the session, when you could just click send me some more information, and we'll get you that information. And third and finally, if you've been elected a Best Doctor, and we run a nationwide poll every 2 years with the help and assistance from Gallup, if you've been elected a Best Doctor, you're eligible to work on our cases as an expert consultant. And if you're interested in working with Best Doctors in our cases and learning more about how all that works, you'll also have an opportunity to request more information, again, during that survey, which will take 2 or 3 minutes to complete, that we'll put up towards the end of today's session. Also, if you want to ask questions to our panelists throughout the discussion, in the lower right-hand corner of your screen, there's a Q&A module. As you type in the question, our panelists and our moderator will be able to see that. I'll also be able to see it. We'll incorporate it into the discussion, or at least allow 5 to 10 minutes towards the end of today's session to address your questions. By participating in today's webinar, you could receive 0.75 of CME credit, and because we are offering CME credit, we need to put up some disclosures up in front of you, so you could read those as we introduce our panelists. So let's get to now Dr. Martin Samuels, and we'll introduce the panel. Dr. Samuels?
Eric, thanks. It's great to talk to you all this evening. We've got a great group to discuss this very important problem of chest pain, which we all know is a very common complaint, sometimes trivial, sometimes extremely serious. And we're going to hear from a number of different perspectives of how to think about what might be the pitfalls in the consideration of a patient with chest pain. So let me introduce our panel members. Lou Levy, who's a longtime colleague of mine, has over 20 years of clinical experience as an internist at the Harvard Vanguard Medical Associates here in Boston. Also has extensive teaching career through his role as a preceptor in the internal medicine residency program at the Brigham and Women's Hospital, and also as an instructor at Harvard Medical School. As well as his medical practice, I believe he serves as the Vice President of Medical Quality at Best Doctors. Also with us today is Dr. Timothy Nostrand, who is Professor of Medicine in the Division of Gastroenterology at the University of Michigan Health System, where he's also served as Associate Director of the Medical Procedures and Digestive Health Center, as well as Director of the Gastroenterology Inpatient Service. His research clinical areas of expertise include esophageal disease and inflammatory bowel disease. His current interests include global consulting in gastroenterology, education and risk management, documentation, and electronic medical records. And finally, Dr. Matthew Sorrentino is a professor of medicine at the University of Chicago and associate director of the Bucksbaum Institute for Clinical Excellence. He's a non-invasive preventive cardiologist with expertise in research interests in treating high cholesterol, hypertension, coronary artery disease. Dr. Sorrentino has been invited to give lectures and run educational programs at more than 500 meetings and events, and has written numerous publications on preventive cardiology, including a recent book entitled Hyperlipidemia in Primary Care. Matt, Tim, Lou, welcome, and thanks a lot for joining us this evening.
Thank you.
Thank you. So this is somewhat of a unique approach. It's based really on errors. We did one last month on back pain. A group of us presented our errors, and we're going to do it again today. And I thought I would break the ice by presenting one of my own first, quickly, and then we'll hear what the other experts think about this. Now, I just want to let the participants know that the other folks here have not heard anything about this case, and this is cold to them. And of course, I had to face this cold myself. So this was a man, 66 years old, who was running on his treadmill at home, and he developed chest pain, which emanated from the left side of his chest, and was dull and pulsating in quality. It radiated into the left axilla, and he said down the left arm to the elbow. He said it did not radiate into his hand. He wasn't particularly short of breath, but he became very anxious about this, and his wife was very concerned, and she basically convinced him to go to the emergency department. He went to the emergency department, and in a very good hospital here in Boston, where he had a normal electrocardiogram, he had a normal cardiac exam. They got one set of cardiac enzymes, which were negative, and they told him he had musculoskeletal pain and that he ought to see a neurologist. And so they arranged for him to see me, and because he was sort of a VIP, people called my office and said, well, you see him tomorrow. So I said, all right, well, I'll see the guy. So I saw the guy in my office, and he told me much the same story. He was having this pain in his chest, which was a pressure sensation that emanated from the left side of his chest around the nipple, and radiated into his left arm and down his arm toward his elbow. He had no history of anything else. I examined him carefully, and I found no neurological cause for this. And so I actually called a cardiologist and said, look, I don't find any neurological cause for this. The emergency department saw the guy last night. What do you think we should do about this? So I wonder if I could turn to you, Matt, and ask you, if you were the cardiologist that I called that day, how would you react to that story?
Well, I think one of the most important things is the story, because a lot of times testing will not be revealing, especially if the testing is done when the patient's not having pain, or if you're testing too early, before biomarkers become positive, before an EKG becomes positive. In my mind, one of the most important things is, what is the patient doing when they're having pain? And the fact that this patient had pain on a treadmill that was located in his chest and went down his left arm puts a cardiac cause of the pain higher on the differential, because it was exertion-related and then went away with rest. So many of the patients we see with pain have stories of resting pain, or pain that lasts all day, or pain that's worse with breathing. Those become more atypical and less concerning. But the exertional nature of this pain, to me, is concerning. And I think cardiovascular workup is reasonable at this point, since he has exertional pain. He's a male at the age where coronary disease occurs.
Would you admit him to the hospital, or would you arrange for him to have an exercise test, or how would you go about actually doing this?
So you need to decide if the symptoms sound unstable or not. So if he was on the treadmill and had been on it for 20, 30 minutes, if he was exercising at a fairly high level of exertion, had the pain, stopped exercising, and the pain went away right away, and does not come back with daily activities, that doesn't sound like an emergency. I think you can work that up as an outpatient. If he's having pain at lower levels of physical activity, just doing simple things around the house, if the pains are recurrent, happening multiple times during the day, even happening at times of rest, then that sounds like unstable angina, and that would be somebody that I think I would admit to the hospital.
Yeah, so let me turn to you for a second, Lou. So this guy, this stuff began, he told us it began on the treadmill. The truth is that by the time I saw him the next day, he still was having chest pain. I mean, this guy was having chest pain, left arm pain, even just sitting in my office. I mean, what would be your gut reaction to something like this as a very experienced internist?
Well, I think that just given his age and the fact that this really sounds to me like angina, again, similar to the points that Matt has already brought up, the exertional quality, the fact that it kind of fits. You're not talking about a young individual with all sorts of atypical symptoms added in. The fact that, he wasn't coming to you saying, this has been going on for the last several months, that I've been from time to time having some exertional chest pains on the treadmill. This sounds like a very new story. So while that could have been an exertional episode that he was experiencing on the treadmill, he may actually be having some ischemia at rest now. So this is the kind of patient that I typically would be admitting for a standard rule-out MI protocol.
Thanks. Tim, I don't want to spend too much time in this case because I'm going to sort of give you the denouement, sort of an embarrassing story from my perspective. Do you have any take on it yourself from your standpoint? Do you think there's any way this is esophageal spasm or some other GI thing?
Well, it's not likely to be esophageal spasm, and the only reason is that esophageal spasm usually isn't constant. There usually is an exciting factor that's causing this to occur. The thing that can occur when you're on a treadmill, of course, is exercise-induced reflux. If he had never had a past history and was starting on a new process, then I think it would be a concern for all of us that this might be a source for his pain as well. But I agree with both Lou and Matt that this is much more likely to be cardiac in nature. And I have anywhere from 3 to 5 patients a year who come to my office with exactly this history, and everybody can't figure it out, and no one has done really a good cardiac evaluation. And then all of a sudden, he's in my office with unstable angina, and I'm not sure what I'm going to do. I had a case about 3 months ago in which I did this. We brought him right into the hospital, and he had already had a fairly massive right-sided heart attack, and now was developing a complete occlusion in his left anterior descending. So I think everyone is telling us that we need to be very aggressive.
Wow. Well, I'll tell you what happened here, and it's a lesson to me, and as I say, a little bit embarrassing. So I called the cardiologist. The cardiologist reacted very much as Matt and the rest of you have reacted, and said, we better put this guy in the hospital. So they put the guy in the hospital, begin the workup, and the next day he developed a rash on his chest that went down exactly along the T1 dermatome, and it was herpes zoster. The 65, 66-year-old guy. And again, I just want to remind people that the pain of herpes zoster, if it's in T1, will go down the left arm out of the axilla in exactly the distribution of cardiac pain. And the pain often precedes the rash and can precede it by quite a long time, a couple or 3 days. And so I found that sort of embarrassing because they sent the patient to me because I was supposed to be a neurological expert. I found absolutely nothing wrong with the guy, sent him back to the cardiologist, and I guess this isn't a serious mistake. I mean, it would have been worse had we missed a serious cardiac disease, but it was herpes zoster. He failed to get the herpes zoster vaccine, which one is supposed to get when you're 60 years old, and he was just an old case of herpes zoster T1. So that's kind of a interesting mistake, huh?
Yeah.
Let me talk to you. Let me turn to you, Matt. You want to present a case to us and see how we do?
Sure. This is a case I saw about a year ago. It's a 69-year-old female patient who has a history of hypertension, and I see her just to control her blood pressure. She came into my office just for a routine check, but she told me that she was having heartburn. She described it as a burning sensation. It was mostly in her epigastric area, but it would go into her mid-chest. She said it occurred various times during the day, sometimes after a meal, sometimes not. would last a few minutes. Many times it would go away if she would just drink some water, but sometimes it would just go away on her own if she was just sitting down. Her past history is otherwise unremarkable. She just has hypertension. She's on amlodipine for hypertension. She takes a baby aspirin a day. She has no allergies, no family history. Her examination in the office was unremarkable. Her blood pressure was in control. So I recommended, why don't you try taking an over-the-counter medication for heartburn for a couple of weeks and see if the heartburn will go away. So about 2 weeks later, she called me up and said that she wanted to let me know that the heartburn had gotten a lot worse. It's now occurring every day. But she told me something different this time. She says, when I get the heartburn most is every time I run up from the basement to my second floor in my house. It happens every time I run up the stairs. And it also has now been occurring sometimes when I take my walk outside. But it always goes away after I get to the top of the stairs and rest for a few minutes. But it's definitely been getting worse. The pain, the burning is feeling more intense. And she had picked up some over-the-counter omeprazole and didn't help the pain at all. So now I was concerned because she's clearly telling me now an exertional component to the pain. So the question is what to do at this point, and I'm debating between stressing her or sending her to a gastroenterologist for the heartburn that's getting worse. Decided to stress her since there was an exertional component. Within 5 minutes on the treadmill, she got her burning pain. Resty segments markedly went down. Long story short, she was admitted to the hospital, had a 95% lesion in her circumflex artery, which was then stented. A week later, she came back to the office and said, Doc, thanks for finding my circumflex lesion. I'm glad that my heart's protected. And I just want to let you know a side effect of your stent is it made all my heartburn go away.
That's a nice case. Tim, I want to turn to you and ask you something about this because, this is one of the oldest stories in medicine, right? The dying of heartburn. You can, read this in the ancient records of medicine. I mean, what is it about cardiac pain that produces this sort of gastrointestinal symptom? Is there anything known about that?
Well, the biggest thing that's known is the fact that when you exercise, you stimulate nerves of the diaphragm, which cause relaxation in the lower esophageal sphincter. In general, that's a relatively small amount of problem, but for people who are maybe predisposed to reflux, they'll get more symptoms very, very quickly. And the heartburn can really mimic cardiac disease. I mean, when you look at all of the papers that have been done on this, it is so difficult to differentiate between the two. We always tell everyone, look at the heart first, and then we'll talk about looking at the esophagus. I've had my own case is I thought I had heartburn when I was walking up the hill from the Seattle Hilton, and I actually thought for 4 days I was having chest pain, treating myself. And when I went to the hospital because my fellow dragged me in, he basically said, you had already had a small heart attack and you were having progression. So I'm very sensitized to this, and I have had 3 stress tests prior to the onset of my heart attack, one less than 1 month before, all of which were negative. So I always tell everybody, keep an open eye about the concept of reflux and the concept of chest pain, because it can occur pretty commonly. And if you look at the distribution of the nerves, literally the nerves are less than 1 millimeter at the spinal cord level and less than 0.5 millimeter in the brain. So therefore, the potential correlation of pain would be very common.
Yeah, certainly these all come in, as we learned from that herpes zoster case, these nerves all come in at around T1, and which explains the radiation, sometimes the radiation down the left arm, the inner side of the left arm like that. I mean, Lou, as a general internist, you hear a lot of stories about heartburn. I mean, GERD is I don't know if there's ever a day that passes that my residents in morning report don't tell me that the patient has GERD. How do you deal with this as a general internist? I mean, most of these people probably do have esophageal reflux and don't have a serious cardiac disease. How do you sort these out?
Well, I think as it's already been pointed out, I think that the general rule of thumb, like Tim said, is to obviously always wanting to rule out the cardiac cause first, and then begin working up the GI symptomatology. But as has been said, it can be very, very difficult. This is reminiscent of a case that I had of a gentleman who was really quite concerned about his health and would often come into the office with this, that, and the other thing, and was actually calling me up once on a trip of his in California when he basically just needed some medications refilled, but then he added that about 4 days ago he had had an episode of fairly severe chest pain that had lasted about 30 hours. I said, well, did you go to the emergency room for that one? And he said, I didn't think too much of it. And sure enough, we convinced him to go to the emergency room out there. He had sustained a rather large anterior MI. Subsequent to that event, he then developed some degree of post-MI chest pain, and he also developed a lot of difficulties with GERD. So this individual became, over time, somewhat of a difficult challenge because he was having chest pain very frequently, and there was a concern, obviously, that one could never write it off totally as, well, this is just GERD, because he had every reason to have ongoing chest pain on a cardiac basis. And these two chest pains, as much as I could tell and as much as his gastroenterologist and his cardiologist could tell, really didn't have very strong differentiating characteristics. So I think ultimately what was done in his case was, through cardiac catheterization, physiologic stress testing, and really trying to eliminate anything that sounded like an exertional discomfort, we were able to kind of manage him over time. But again, he did not really sort out too easily in terms of having a clearly definable GERD symptom complex and a clearly definable CAD complex.
Yeah. Well, so, obviously the moral of the story is that the cardiac disease is a life-threatening, potentially life-threatening illness and ought to be taken seriously when everything in this border zone. Tim, how about an approach from a gastroenterologist? Do you have a case that you could tell us about?
Yeah, I do. This is a 52-year-old man who had a 4-year history of pretty characteristic heartburn and chest discomfort. He was initially documented to have this with 24-hour monitoring, and then that 24-hour monitoring was then subsequently followed up by treatment with omeprazole, and he actually did remarkably well. Then 6 months before he came in to see me, he was now complaining about the same chest pain, but his once-a-day omeprazole hadn't really helped him. So the next thing was we tried to increase his proton pump inhibitor therapy, and we asked him about the timing of this. It's important for everyone to remember that this is a timed drug. You have to take it between 30 minutes and an hour before a meal, or it doesn't work at all. Literally doesn't work at all. You can't take it whenever you want. And we went to twice-a-day dosing, and he still didn't get any response. Now, he didn't tell me that there was any inciting factors. I asked about new medications. He wasn't on calcium channel blockers. He wasn't taking any new drugs at all. He wasn't doing anything that incited this at all. So I couldn't figure out what was going on. So what would everybody do now? What would they do? I can't think of anything more I was going to be able to do right then. So what do you think?
What do you think, Matt? What's your take on that case?
So I think one of the most important things to remember about chest pain is that it's really a syndrome. It's not just the pain, because the pain can overlap all of these different things. You've got to really put it together with the whole syndrome. What makes it start? What makes it stop? How long does it last? Where does it radiate to? What makes it better? If you take something, does it make it better? The cases that we've talked about already had an exertional component. Unless it's a acute coronary syndrome, most chest pain is going to occur when you ask the heart to work harder. If it's going to work harder and bring on pain, and when you let the heart relax, it's going to go away. I usually tell my residents and students that if a pain only lasts for a second or so, it's never the heart. If it lasts for hours, it's either a heart attack or it's not the heart, because angina usually lasts 5 minutes, maybe 10 minutes. It kind of peaks and then goes away. So going back to this gentleman and trying to figure out what's different about the pain this time. Is it more exertional? What makes it go away? How long does it last? can maybe help you decide if a cardiac workup should be done.
That's perfect. We asked them those questions, and what I asked them was simply, are you doing anything new? We said, well, yeah, I am going to the exercise club right now, and I was doing 20 chest pulls every day, and then was going up to 60 chest pulls every day, and noticed no pain during the exercise at all, not a single bit of pain, and couldn't correlate this, but his pain was becoming progressively more constant. So I examined his pectoralis muscles, and on both insertions at the sternum and in the left humerus, he was exquisitely tender, and it completely reproduced his discomfort. We basically stopped his exercise for a short period of time, and he did fine. My lesson I learned there is you got to take another better history when it changes, because reflux pain doesn't usually change unless there's weight gain or some new medication, something else going on. So that was the lesson I learned from this.
Well, Tim, I think that says what I was saying also. If you really take the time to take that history, many times it can point you in the right direction. And what was important from that history is that when he was doing that heavy exertion, he didn't get the pain, but he got the pain afterwards. So all of a sudden, musculoskeletal goes way up on your list. You know, we shouldn't be sending everybody who has GERD symptoms for a stress test. We're going to get a lot of false positives if we do that, and false negatives. Instead, it should be that whole syndrome. If the syndrome suggests that it could be the heart, yeah, then consider it. But the vast majority of chest pain you see in the office is not going to be your heart.
I agree.
Let me ask you something, Tim. I mean, a lot of people say that they'll take an antacid or take a PPO or something, and the pain or discomfort will go away. How much stock do you put in that? If you hear that story, does that make you believe that you are dealing with reflux, or what degree of confidence does that give you?
Well, as Matt pointed out, it doesn't necessarily rule out the heart. I more commonly see a situation when the patient is given a GI cocktail in the emergency room and gets great relief. We've had 2 deaths related to that, too. So you've got to be a little bit cautious. But if the patient tells me they're taking an acid and they get instant relief, that means acid is probably involved. And interesting enough, reflux can induce coronary spasm. So the argument would be here is that a patient predisposed to heart disease still might be heart disease even with relief pattern. But the argument would be here is that, yeah, I would put some real credentials into that as a potential source for his chest discomfort. So I do think that using antacid is good. The fact that he doesn't get relief with proton pump inhibitors is never a reason for ruling out reflux as an acute pain, because it takes anywhere from 2 to 3 days to build up proton pump inhibitor blockade.
Well, that's a very instructive one. Lou, how about presenting a case from your experience for us?
Sure. Well, this is a case of a 65-year-old gentleman with a personality disorder who has actually had about 5 admissions over about a 2-month period of time, all for the same complaint, chest pain. And he had each time been admitted to one of the big academic hospitals in Boston, had a complete cardiac evaluation. One of the hospitalizations even went as far as a cardiac catheterization. All of his examinations were totally negative, and he was, on his most recent evaluation, he was actually admitted to the coronary care unit, and he literally wouldn't get out of the coronary care unit. He was sick and tired of it all. He said, I keep on having chest pain. Nobody can really figure this one out. I'm not going home. And they basically brokered a deal with him to sort of say, well, we'll try to arrange for you to, we really can't keep you in the hospital forever, and we've done everything we can. We've literally done every test in the book for evaluating your chest pain. And he was a very cantankerous individual, not the easiest guy to deal with. But we'll get you an appointment with your primary care provider today, and, maybe he can calm you down a little bit. And I saw him in the office that day. It was one of these add-on appointments with no time in the schedule, and really the mission was calm this guy down, because this is basically the deal we struck. He just needs to come up with a management plan here, because he's got this atypical chest pain disorder that seems somewhat refractory to, the high dose PPIs and all the other medications. So I think that, on that day, in that setting, I felt like mission number one was to make this guy feel well cared for, and make sure that he knew that we were there to help him in terms of the long-term management of chest pain syndrome. But as events turned out, within approximately 24 to 48 hours of that office appointment, he did have an MI and was then readmitted back to the hospital. So I think that, in terms of the learnings there, I think that there was just an overwhelming sense, if you will, of anchoring bias in terms of, this guy's got an atypical chest pain syndrome, which is definitely not cardiac. You've got to help us, in terms of managing him. And I think, in retrospect, he was a little bit overly packaged, if you will, in terms of my own involvement with him at that point in time.
It looks like we actually lost Marty's phone call there. So, if Dr. Sorrentino, do you have
I can actually, Kelly, I could jump in. I have a question for the audience for the panel. We'll buy some time for Dr. Samuels to dial back in. So I'll pose the question to Dr. Sorrentino initially, and then maybe we could go around the virtual room here. There's a question from one of our attendees, and hopefully I'll pronounce all this right. He asks, what about the iatrogenic causes of GERD that are caused when cardiac medications are given after a cardiac event?
So I agree we have to always keep a wide open mind of what could be causing symptoms. And many times some of the things we do for our patients end up causing symptoms that can be misinterpreted as being cardiac pain. A common one is we tend to give patients with heart disease statins, for example, and that can affect muscles and cause muscle pain, and some patients will interpret that as maybe being from their heart. Some of the medicines we use may upset the stomach, cause nausea and pain, and that certainly can be interpreted sometimes by the patient as coming from the heart, and it is not. But again, I think the best way to interpret this is a very careful history, asking what brings on the pain, what makes it go away, because if it's due to a medication, it'll be fairly continuous off and on throughout the day, not necessarily exertion-related, whereas if you get a clear exertion story, that suggests it might be the heart. The hardest patients are the ones who have chronic pain syndromes, because it's like the boy who cries wolf. You never know if this episode of pain is just their chronic pain syndrome or if it's something real. But you have to think about it every time. Is there something different about this pain from the pain before? What makes this episode more unique? And then keep that open mind.
That's great. Thank you very much, Matt. I think there's some questions coming in from some of our attendees, and I wonder if Kelly can get some of those questions. I saw there was a question from Dr. Masulis.
Yeah, so Dr. Samuels, we were just actually going through the first question on the iatrogenic causes of GERD. I didn't know, so before we move on to the second question, because I do see Dr. Masulis' question, I didn't know if Dr. Nostrand or Dr. Levy, did you want to jump in? Did you have any additional comments on the question on iatrogenic causes?
Yeah, probably the most important one that we see is the use of antibiotics or the use of calcium channel blockers. Calcium channel blockers are particularly bad because if you increase dose, it's almost linear decrease in lower esophageal sphincter pressure, and that will induce more reflux. It just should be recognized because we can treat that, but it is something that we commonly see. And then, of course, antibiotics and pill-induced esophagitis is increasing dramatically because people have a tendency to take medications at nighttime and go right to bed. And when that happens, that pill will literally be in their esophagus the entire night. and the following night they may very well wake up, the following day they may very well wake up with substantial pain. So I agree with Matt that we should always get that history. History is by far the most important. And this anchoring bias is going to become more common as electronic records become available, because everyone will see that everyone is copying and pasting the history into the chart, and therefore that anchoring will be a problem. So that's something we have to keep in mind all the time.
Lou, any comments about that?
No, I agree. I mean, I think that the one thing that I have noticed is that there are many patients that are labeled as having esophageal spasm as the etiology of their chest discomfort, yet at least in terms of the gastroenterology community in the Boston area, there isn't often a really rigorous evaluation of esophageal disorders. People don't go for esophageal manometry all that often, and often people are just given this diagnosis almost as a diagnosis of exclusion. So I think that one really does have to be wary of that esophageal spasm as a diagnosis, because often there's very little objective data there to kind of back it up, other than, well, it kind of sounds like esophageal spasm to me. I don't know, Tim, if that's your experience as well in your community.
Oh, absolutely. It's a very common problem. And the reason being is that most people don't have access to any of the newer types of manometry and monitoring. So therefore, they have a tendency to already make the diagnosis and perseverate on that diagnosis. Yeah. So I think that we need to kind of keep that in mind all the time. And high-resolution manometry is certainly improving, and we can get esophageal spasm pretty easily.
Yeah, it's it is true that the electronic medical record, the business of cutting and pasting, and the repetition of the same error by just pasting it into the record over and over and over again is a really big problem. And I mean, is it true, Tim, that GERD is really an epidemic disease? Is it really increasing in frequency and is a major cause of this kind of chest discomfort? What is because when I was certainly training in medicine, we knew that such a thing existed, but everybody didn't have. Everybody was not on PPOs. What is your take on that?
Well, all you have to do is look at the obesity curve here. If you look at the obesity curve, that's basically the linear increase that we're seeing in GERD cases. We're talking as much as many as 50% of patients will have GERD in this country at some time. It's usually not the cause of severe chest pain up front, but it is just like Matt was talking about. We now know if you go to the emergency room, the chance that your esophagus is going to be the final diagnosis is well over 50%. The heart is only about 17 to 20%. We're not using the ER very well, and we're sending the patients to the ER based upon a very small risk of developing a myocardial infarction. Deadly risk, but clearly we still should always keep that in mind. I really think that this is a common problem, and we're beginning to see more and more of it because GERD is a common problem, and people have a tendency to gain weight, and when they gain weight, GERD is common. For every inch on your anterior abdomen, we increase the pressure in your stomach 10 millimeters of mercury. So if you increase your waist size 5 times, there's 50 more millimeters in the stomach causing reflux. So reflux is going to be there.
You said something interesting before that I didn't know, and I want you to expand on that. You said something about reflux actually causing coronary vasospasm. Did I hear you correctly?
Yes.
What is the evidence for that, and also the mechanism?
It's small anecdotal cases that have been done. We did 5 cases of patients who had reflux-induced pain, and we actually did coronary angiogram simultaneously when we did acid infusion into the esophagus, and we were able to show that acid infusion in patients with known coronary disease causes coronary vasospasm. So it's more for the patient who has heart pain and angina that reflux can cause them.
Well, that's new to me. What does the cardiology community think about that, Matt? This idea of vasospasm, coronary vasospasm being actually caused by esophageal reflux.
The problem with coronary vasospasm, it can be an elusive diagnosis. It's hard to diagnose. You need to have typical angiographic findings during pain, or you have to observe it during an angiogram. So it's really hard, which is why most of the cases of spasm that we see are small studies like this or anecdotes. On the other hand, we know that if you have underlying coronary disease, especially if it's active inflamed disease, arteries tend to spasm, and it doesn't take very much to cause that spasm. So the most common spasm we'll see is patients with known disease. This disease is active disease, and many features can lead these arteries to spasm. Again, it's trying to get a good history and figuring out what the instigation of the pain is to try to figure out what's causing the actual pain syndrome in that patient.
So certainly one of the main takeaway messages, I think, of this discussion is that the old basic blocking and tackling, getting back to the history, trying to find out what it actually makes it worse, what makes it go away, still is the most important aspect of this. Are we all in agreement that that's true?
Yeah, I agree, although there's one thing to keep in mind, and that is that coronary artery disease can change very quickly. You can have a normal angiogram, a normal stress test one day, and have a heart attack the next day. And so just because you've had testing that said that everything was fine doesn't mean a plaque can't rupture and you can't have a coronary event. I think it does go back to that history to try to figure out what's going on, but especially in that patient like Lou's last patient who had a chest pain syndrome and kept coming back for chest pain, something changed and he had the heart attack. And so you just got to keep that index of suspicion and take that good history, and if you think it's coronary, look into it.
Yeah. Are there any other questions from our attendees? Because we're sort of running short of time. It's almost 8:45 here on the East Coast. Any others there, Kelly?
Yes.
I see there's several attendees, but I don't see any questions.
We have one question that was, first of all, Dr. Sorrentino answered the latest question, I think, from one of our attendees, in that what could have been done to avoid the late diagnosis. I don't know if Dr. Sorrentino, you wanted to expand upon that, but that was the question that you seem to have just naturally answered. And then the latest question that came in that's sort of related to what your last comment was is, what is considered the standard of care regarding stress testing once acute MI has been ruled out in the hospital?
What is the standard of care there, Matt? Once an acute MI is ruled out,
the important thing to remember about a stress test is a stress test is going to either increase or decrease your probability that you have a significant coronary occlusion, usually defined as a 70% narrowing or greater. In a patient who presents to you with very classic angina at very low levels of exertion, stress test is not going to be very helpful. You expect it's going to be abnormal, and so doing a stress test is not going to help you make a diagnosis, and if it's not abnormal, you're not going to believe it. So somebody who has easily induced unstable angina-type symptoms, you should just admit them to the hospital and do an angiogram. On the other hand, if you've got a patient whose pretest probability is extremely low, a patient who has no exertional symptoms, very atypical symptoms, no risk factors, very young age, a stress test is more likely going to be a false positive, and it's not going to help you. So the patient you do a stress test in is one that your pretest probability is still high enough that you're concerned about the patient, and a stress test, if it's positive, will either increase your likelihood there's disease or decrease your likelihood, and you'll do something else to evaluate the symptoms. So it's really that intermediate risk patient where the stress test is most useful. There really is not a good role for stress test in asymptomatic patients, except for very rare times. It really is to evaluate a symptom and try to understand what's causing that symptom.
So that's a beautiful way of sort of stating that is an hypothesis, that you need to know what that pretest probability is, because if it's low, then your chance of a false positive is probably 50%. Your chance of a false positive is probably as good as a true positive under those circumstances. So that's very, very good advice. Well, I think we're just about out of time. It's 1:15 here. We've been going for 45 minutes, and we've heard a lot of very interesting cases. I think certainly the lessons of taking a careful history, trying to hear about what causes and what relieves the pain, probably the main point here. Before turning it back to Eric, I just want to thank Lou Levy for his participation, Tim Nostron, who's calling in from University of Michigan, and Matt Sorrentino from the University of Chicago. I think it's been really a very helpful discussion. I've certainly learned a lot today. Let me, with that, turn it back to Eric.
Thanks, Marty. Thank you, everyone. It was a terrific panel. Before we wrap up, I just wanted to remind all of you that we have this feedback form in front of you, and if you joined us late, a few important things for you to remember and you're able to request as a byproduct of today's session. Because Best Doctors is so committed to the education around diagnostic accuracy, providing webinars like the one that you've attended today, and you'll have opportunities to attend one every month, we want to get you all involved in some of our actual clinical programs. And we're conducting a pilot program with the MGMA where you could have access to our service for your patients. So that's something you get more information from the feedback form. And we're also interested in working with many of you who are Best Doctors if you want to work and be consultants on our cases. And you could request more information about that through the feedback form in front of you. So this will mark the end of our session. Oh, and again, a reminder, you could also earn 3/4 of a CME credit for attending today's webinar. So thank you again to Dr. Samuels, to our entire panel. Great session. We hope to see you here back next month. And this will mark the end of today's webinar. Have a good evening, everyone.
Thank you.
Bye.